Good morning and welcome to this Australian Centre for Value-Based Healthcare webinar. I'm Lisa Roby, the Engagement and Business Director at the Australian Healthcare and Hospitals Association, and it's my pleasure to be your host today. Before we get underway, I'd first like to acknowledge and pay respects to the traditional owners of the lands on which we meet, wherever people might be participating today, and pay our respects to elders past and present. I also extend that respect to Aboriginal and Torres Strait Islander people who are joining us here today. Today we're joined by Dr Jack Cochran, the recently retired Executive Director of the Permanente Foundation and author of Leader, Healer, Partner, a Manual for Effective Physician Leadership. Jack's had an illustrious career that's included both executive and clinical leadership roles, and it is these two very different but interlinked perspectives that have given rise to his books and to today's webinar. Jack will be interviewed today by Dr Jas Saini. Jas is a specialist GP and a practice owner from West Pennant Hills in Sydney. He has a mission to prioritise the patient experience, nurture care teams, deliver innovative solutions, and restore joy to the practice of medicine. Now, Jack has kindly agreed to take questions throughout his presentation and in fact has encouraged everyone to challenge him. So if you have a question, please type it in using the Q&A section at the bottom of your screen and we'll work through the questions as we are able. So with that housekeeping out of the way, I'd like to pass over to Jas and Jack.
Good morning, everyone. Good morning, Lisa. Good morning, Jack. Thanks, everyone, for attending today, and we're looking forward to a very lively conversation with Dr Jack Cochran. Lisa and I have had the opportunity to talk to Jack on a number of occasions in the past, and we can assure you that it's going to be a very exciting conversation. Lisa, thank you for the introduction, and Jack, I'm hoping that you can perhaps tell us a bit about yourself.
Good. Can you hear me well?
Yeah, that's all fine, Jack.
All right. I don't have a good video of me yet. It's not that I need that, but so as you have referenced, I am a physician by training. My only professional training is as a surgeon, but I practiced for several years in a private practice, and then I joined an organization, a system of healthcare called Kaiser Permanente, which some have heard of, some have visited, but it's rather than a solo single practice, it's a system that has physicians and hospitals in an integrated delivery system. And so that's where I then moved my clinical space. And then when I was there, I became involved as a board member of the group and then into leadership. And so I was a president of a medical group in the state of Colorado, which in the United States is a state with maybe 4 or 5 million people, and I was the president of a medical group that was caring for about 600,000 people. And that was a big shift. As I often say, the shift was quite remarkable to me because, number one, in surgery, I had 4 years of medical school, 6 years of residency training, and extensive monitoring and mentoring and observing and measuring and examinations and certifications, so that I knew that I knew what I knew. But then in a year and a half, I went from being a full-time surgeon to being president of a medical group. And that training was quite different. It was just in time, on the job, and trial and error. And that's not just being tongue-in-cheek, that's quite serious. And so then I did that. And the Colorado region, as it turned out, did well. And that's because we had some tremendous people, physicians, nurses, physios, et cetera, that worked together in a very collaborative way and really made innovative improvements in the care process. And then I was selected to be the national leader, and the national leader for the Permanente physicians is the executive director of the Permanente Federation. And I worked as a full partner with the health plan CEO for 8 years, and that was at the top of the organization on the physician side. When I left, we had 21,000 physicians and 11 million members that we cared for. Since retirement, I've been writing, I've been teaching, and I've been trying to assist people that did the jobs that I had before by trying to help them be more competent and more confident in their leadership skills.
Wonderful, Jack. Now, we're getting a couple of questions in regards to people being able to see you. Unfortunately, for some technical error, we're not able to get the videos up today, so I do apologise for that. So, Jack, one of the questions...
My start video it says you can't start your video because the host has stopped it.
Yes, I'm seeing the same. So maybe Lisa's got a solution to that, but I'm sure she'll be working on. So for now, I think we'll continue our chat. So, Jack, why is this conversation important today?
I think it's important because the issues that we face in healthcare are really quite global. I would have to start that comment by saying I fully understand that as you look from Australia at the American system, you don't say, oh gosh, we want to be exactly like that. That's the system we want. I understand that. We have a very large country with a lot of pockets of excellent care in areas where it doesn't go well. And so I don't recommend you emulate the US system as a model that you completely follow and design yourselves with. But on the other hand, there are some very excellent work going on, breakthroughs, learnings, etc. And I think that the reason I think it's important that we have gatherings like this is to continue to explore what each other knows, what each other has learned, and understanding each other's issues, because not only are they common, but sometimes the solutions are rather different, and we haven't thought of them as much as we could or should.
Yeah, and I suppose, in the Australian context, certainly, Jack, we do, from time to time, get a question of what around the world we should emulate and what we should quite rightly avoid. And certainly from being across to the States and seeing what it is that you guys do, you display some of the best, and at times, if you don't mind me saying, you also have some of the worst of the worst. So certainly appreciate your comments there. Now, you're the author of a new book called Leaders, Healers and Partners. Could you tell us a bit more about who are these leaders, healers and partners?
Yes. So because I spent the last 17 years of my professional career as a senior leader of physicians, I naturally oriented some of my thinking and writing toward physicians. But as I learned and as I wrote, I realized it's really a book that has very global application. And it is not designed, it is definitely not designed to advance or advantage or protect physicians. What I have seen in my 30 plus years of practice and leadership is much change. Many things have changed. A lot of things have gotten better. We've gotten more treatments, really miracles, breakthroughs, all kinds of things that have really advanced the opportunities to take great care of patients. And at the same time, we continue to have unevenness of care, of quality, problems of safety. We have uneven equity and access. And so while we've made a lot of advances, there's this interesting contrast that we have tremendous challenges as well. And in the global world, but especially in the United States, the issues of cost and affordability have become very, very problematic for the average family, because we have a lot of personal cost sharing. And so it has become really problematic for families to make decisions around actually rationing healthcare. Can they get something done? Should they get something done versus some of the shared costs that they have to participate in? So because of that, the old model, which was, kindly, gentle, well-trained and compassionate physician and patient with nursing staff, et cetera, together in an office visit or a hospital visit with a paper chart, worked in a world of less complexity. But the complexity of knowledge, information, and technology over the last decades has really made that very difficult. And so we now need to use technology. We need to have teams. We need to work together with different types of physician, primary and specialty care, and use nurses and physios and pharmacists in very collaborative, very team-oriented ways. And that's a new world. That is the information age, for which most of us did not have training. We were trained to be individually competent, individually examined, and individually successful. And that was probably because of the intensity of some of the science and the things that we had to encounter. But it really didn't prepare us for this world of complexity, where we really need to lean on other people and learn with other people. And so as I developed the thinking around what should doctors be, we're not the most important people in the world. The patient is absolutely the center of the universe for this thinking, but we do have disproportionate impact. People do look to us for opinions and for our counsel, and we are important members of teams. So I realize that because patients encounter the system physically, socially, psychologically, financially, and other ways, we have to be more than just clinicians. We've got to step forward and lean in to say, how do we participate in these other problems and other solutions? And an example is something like IT. If we consider IT as an organizational construct, that problem down on the second floor, and when are they going to get it right? Because we're doing the important work and they're really slowing us down or making us very, very cranky. That's not physician as partner. That's physician as tyrant, or a physician as victim who's sitting on the sidelines saying, somebody else please fix this. And what we have to do is to lean in and say, let me listen to you. Let me hear what the IT issues are, because I'll bet you I can also shed some light on what my and my patient's issues are. And all of a sudden you start to share, listen, acknowledge, challenge, and bring each other's knowledge, sort of co-create reality and to begin to learn together. It's very powerful, and there's no shortcuts to this, and it's not about hiring smarter practitioners, whether they're doctors or nurses. It's not about that. It's about learning how to develop a culture where we actually do understand partnership. And again, the role of leadership is we cannot sit on the sidelines when our patients have problems beyond just their immediate clinical issue. How do we understand what good ways to work with and partner with people who pay for healthcare, people that are in the government, people that are in the hospital world? So healer, leader, and partner simply says, we have to embrace, we have to reboot our leadership for the 21st century, and we've got to be more involved in more issues that impact our patients, because every time we opt out, the patient loses an important voice. And I'm saying we in the sense of, I have talked mostly about physicians because that's been my responsibility, but it applies fully to everyone on the clinical team. We need nurses, pharmacists, physios, aides, everybody to be healers in terms of these vulnerable patients, and also leaders to lean in and to say, I have an opinion, I have a thought, and let me hear yours so we can work better together. And that's embracing the role of partnership. It's really saying the old rule of individual competence just doesn't have enough power, and it doesn't have enough capability to solve today's much more complex problems.
So, Jake, I'm going to be a bit controversial there and say, based on what you've just told me, that I haven't been trained to do that, and I don't get paid to do that. And what we're talking about here is leadership. And the question you asked very rightly is, what should doctors be? Well, with the old adage is that we're there for our patients, and that the most important thing that we can do is serve our patients when they're directly in front of us. So what you're suggesting here is that this is a different world, and in fact, our patients in their involuntary capacities are relying on us to lean in and do something more. But if we don't have those skills, how do we do that?
Yes, but by the way, technologically, I think the bad news is the video is working. Is it working for you? Anyway, the video is working here. No, we don't have the skills. Hence, that's why I said my training as a surgeon was extensive and long, with lots of monitoring and mentoring and examining and certifying. And yet my job training for leadership was more on the job and self-trained. And so I recognize that. One of the other things that people say is, well, let's just go out and also add MBAs. Let's add business degrees. And I would say that both the MD and the MBA, and I would add the RN and the RPH, et cetera, they're all good degrees, academically sound, but none of them are focused on an in-depth development of leadership. Leadership is another skill set. It's another way of learning and thinking. And that's why I wrote this book. This book has good substantiation from the literature, from things I've read, books, articles, et cetera, but it is highly, highly practical. I said, if the book were successful, it would never be a commercial success where it was on somebody's list of bestsellers, but it would be a book where somebody like Jas would read it and say, wow, that really helped. I'm going to give it to 5 of my friends, 5 of the chaps I work with, 5 of the women on the team or whatever. So it's really about saying it's kind of a manual. It's a very practical set of lessons that are approachable, pretty simple, often not easy, but simple. So I wrote the book trying to say, how can I translate and transmit a lot of this on-the-job training, self-training that I've had? Because there's more leadership training for physicians and nurses than there used to be, but there used to be almost nothing. And even today, it's a little bit helter-skelter. It's really not necessarily all that coherent. But I tried to say, let's make something that's practical that people can use. And so I talk about difficult crowds. I talk about measuring performance. It's the kinds of things that give us concern and worry as we lead our peers, friends, and other people in healthcare. So I think that the book has an upside of being very practical and something that does not require a whole bunch of other training to learn from it.
Right. Now, I've read your book, Jack, obviously, and that's how I've come to the interviewing you today. And I think absolutely it is a very practical and easy to read book. And part of what often falls apart for us is that, you know, we read these books and there's a gap between the practical reading of something and actually implementing it. I think there is certainly some very useful tips that you put in there that actually makes that quite easy. There's a great question here from Grant Phelps, who's one of our audience members, and I'm hoping that I can read that out to you, Jack. Grant's mentioned that he's a medical leader with the skills and training and experience. How do you resolve the problem I repeatedly see, that clinicians and doctors in particular are content with their care? They don't see a need to change to improve or to think in systems terms. We train people for the one-on-one, but we don't train people for working in systems.
Right. Absolutely. Hallelujah. I totally understand that question. He's totally correct. But it was also true, and even more so 15 years ago, when I said, I can't just continue to sit on the sidelines and acknowledge that and recognize that and live with that. I have to be more proactive. I have to be more of an activist in this. And so very much like major change, if you know the teachings of Everett Rogers on leading change, you know, you have your early adopters. You have people probably on this webinar who said, I can't sit by. I've got to step forward and try to make a difference. And then you realize that you were out there in a very small group or by yourself. Where is everyone else? And so the early adopters are often people that have to do it on their own with a certain amount of courage and a certain amount of willingness to learn and to learn the hard way. But I don't know a way of converting people quickly. What I do know is if we become leaders who can lead with clarity and compassion and show that we can listen and collaborate and yet be strong and courageous. There's an interesting sort of dichotomy here. We want our leaders to be good listeners and empathetic and compassionate, but also be very clear and very strong in their ability to make decisions and to lead. And none of those skills are innate. There are definitely leaders who are born with more skills and more capability than others. But much of it can be developed and is developed. And I think the reason that I find it useful for me to participate in an event like this is just those touch points. Who is the coalition of courageous colleagues that I'm going to continue to be able to keep in touch with? I have had about five or six major contacts with groups from Australia, 3 in the US, 2 down under, and this one. And I continue to develop a coalition of people that the second time we met, we reviewed some of the things we learned the first time from each other. And so he's right. Grant is exactly right. It is not simple. It's not easy. But I do know this. It's not like a vaccine. You say, okay, we're going to bring the leadership vaccine out to West Sydney and we're going to inoculate 300 doctors and in 14 days they'll all be leaders. It is a hands-on, one-person relationship, one conversation at a time development. And we have to model the kinds of traits and expectations that we think are important, and we've got to live them. we are at a leading edge because we are so deeply trained and enculturated in individual competence. And the other thing, if you read the opening of my book, I try to talk to my brothers and sisters in medicine who have become frankly angry or disillusioned or disappointed or sad or depressed, that whatever happened to them when they were 21 and they dreamed of this career has changed. And too much of it changed around them and to them and not by them. And I get that. And I understand that. And I feel for that. On the other hand, I don't know of a switch that we can say, okay, let's pull this switch and that will change. I think it's the hard work of saying, you know, we're here, it's us. And if we do nothing, we will guarantee a future will continue to change and be directed by other people. But if we step forward and say, I'm just going to participate. But as I alluded to earlier, the two roles that don't work, healer, leader, and partner work. The two roles that don't work are physician or nurse. When I say physician, it's a global term, but I've just spent 18 years leading doctors. Physician as tyrant, physician as leader, as victim, says it's somebody else's fault. If we just get the hospital people or the IT people or the insurance companies or the government to shape up, everything will be okay. Those are all partly true. We do need other people to change, improve, and be better partners in this. On the other hand, if we say we're going to wait for them to change and then things are going to get better, we are victims and we are kidding ourselves. And that's one of the spirals that has led to more and more physician dissatisfaction. And the other role that doesn't work, which is physician as tyrant, saying, which is, I'm in charge here, I've had more years of training, do things my way or else. You can actually get things done in the short run by being like that. And some people stay like that for years. But it's not how you build a long-term community or a culture or an environment in your medical staff to really have an organization that embraces innovation and learns together. And those are all just words until you actually roll up your sleeves and do it. So he's right. There is no panacea. There is no quick fix, but we have to lean in and stay in the game. That's why when I retired from full-time practice and leadership, I said, I can't just go off and work on my fly fishing. I have to maintain a connectivity with people that I have shared with. And that's why I have a good connection with people from Australia and New Zealand is, you know, I'm still learning and I'm still teaching and I think it's still valuable. So it's a long journey, but remember the 21-year-old idealist. And the 21-year-old idealist was in all of us. And we were in our teens and working ourselves hard to make good grades in whatever school we were in to become nurses or doctors or IT executives. And in medical school, we had to write a couple of paragraphs when we applied to medical school about why we wanted to become doctors. And go back and read your own 2 paragraphs. And for some, it'll bring a tear to your eye because you think, who is that and what happened? Because that person was the 21-year-old idealist, brimming with hope and brimming with the desire to be a healer and a compassionate, well-trained clinician. And so that spark has gone very dim in many people. And all I can say is, I just can't quit. I just can't quit. I just can't say, you won. The system got me. And the reason is, one of the things that I was fortunate in my career, and it wasn't anything I did, but whether I was a student, a resident, a practicing surgeon, or an executive, I never lost focus of the fact that there was only one group that was primarily needed by me, and that was the patient and the family. Because I learned later it was also my colleagues, but early on I thought, every one of these situations, patients and families, patients don't want to be patients. The role of patient is involuntary. Nobody woke up this morning and said, gosh, it's been a while since I was a patient. I'd like to take another shot at that one. No, it's involuntary, and they depend on us to be compassionate, competent, knowledgeable, and available. And so I can't quit. I can't give up on that, even though there are days where the journey is hard. I was in Maine last week for 3 days. And I saw a group of people, nurses, doctors, physicians, IT executives, finance people, come together in a situation where they weren't particularly aligned and weren't particularly motivated by similar goals, they didn't think. But they were sincere. And they leaned in and they hung in there. And after the 3 days, they were not perfect. It wasn't a miracle. But I was amazed that because of a very open process of listening to each other, acknowledging what you heard, adding my context, adding my 2 cents, and then continuing to co-create a new knowledge base, they started to find solutions that they could understand that were important to everyone. It's, when I look at the US Senate, Congress, White House, and how they are working today, I think, where are the role models? I mean, it's amazing how people will take contrarian stances as their only responsibility. So it's not easy, but if we give up, then somebody else will fix it in ways that we will be even more unhappy about.
That's great. Thank you, Jack. Look, there's a lot to unpack there, and I think probably 2 key points that I've picked up personally, which is one, this idea of the 21-year-old idealist. I think we should always be grounded by our beliefs, particularly the ones that we held early on. The other is the lonely road that people often travel as leaders. And one of the points which you mentioned here was this coalition of courageous colleagues, which I think is a fantastic string of words. In your experience, how important is it for leaders to have a circle around them of people that they can trust? How essential is that?
How much hyperbole can I use here? It's mandatory. It's mandatory. So when I said my training in leadership was on the job, just in time, trial and error, fortunately, I knew that. Fortunately, I didn't have this personality that says, I have got to show that I'm omniscient. I've got to show that I'm powerful. I've got to show that I'm right. Fortunately, I think my inexperience in some ways developmentally was a positive, because I thought, oh boy, I am, they want me to do this and I am really in trouble because I don't have deep business knowledge or deep business training or finance or IT, and yet I'm in a chief executive role. And so I really did have to learn how to listen, and not only just listen to people in every setting I went to, because they were actually accustomed to people who tried to come in with answers and essentially quash their inquiry by giving them quick, pithy answers. And these are smart people. If you bully them or fool them, you may get by with it for a short time, but you will never create an innovative, excited culture of people who want to make a difference, who want to give discretionary effort. By that, you've got to be a good listener. You got to acknowledge what they say. You've got to add your information. So those are just so important. And then as part of that, you have to have a team around you. If your own personal needs are such that you have to have people around you that say, oh, Jack, that's amazing. That's brilliant. You're just so right. You're so right on. If that's what you need around you, you will forever set your standard way too low, because nobody is smart enough. Nobody's experienced enough. Nobody knows enough. You don't need people around who want to beat on you, but you need to develop a team and a culture that says, help me, please. I had this one vice president, and she used to laugh, because I had a hard time coming to a final conclusion about making a personnel change, for example. I paid for it more than the person that I was moving or removing in many ways. But she came up to me, she says, hey, Jack, I just want to let you know you made your mind up last week. And I said, what do you mean? She says, you've got the look. Your look changes once you make up your mind, and you've got the look. And I said, really? She says, oh, yeah. She says, you stewed about it for 3 months. You should have stewed about it for 3 weeks. But you made your mind up last week. And I thought, isn't that interesting? And I think she was right. So you have to have people around you who are willing to say, hey, buddy, I like you. I believe in you. I think you say a lot of good things, but you are so wrong about this. I had a little brainstorm at one time that I thought we had a different way to leverage compensation. And if there's a third rail for executives, it's compensation for professionals. But I introduced it before I ever tried to implement it to a group of my most trusted, high energy, independent, feisty leaders. And one of them, who I value the most, came up to me and says, "Well, Jack, that was really bad." And I said, "Really?" I said, "I thought it was awful. It was so hard on me." He says, "No," he says, "you have lost your mind and you've lost your values." And I said, that pretty well sums up my total worth, right? And so I spent some time listening to people, and we had about 3 or 4 more meetings, and I did a lot more listening, and I got a lot less defensive. And he came up to me after the 4th meeting, and he says, "I just want you to know that I'm very relieved." And I said, "Why?" He says, "Because you've only lost your mind." And I said with a great sense of relief, "I think that's good, right?" He says, "That's very good, because you haven't lost your values. You're just wrong. Before you were wrong and evil." And I thought, I came to understand, and all of us that probably in this room are going, "Ooh, I know those people. They make me nervous." I came to understand what a gift that was. He had enough courage and enough humanity to say, "Jack, you're full of it. You're wrong." And when he said, "You haven't lost your mind, you haven't lost your values, but boy, you've still lost your mind," I didn't feel the full sense of relief I should have. But essentially he was saying, "I can still trust you. I can still trust you, but you're wrong." And that's why, if you see in my book, I live on simple learnings like listen, acknowledge, and challenge. The other is value, dissent, and challenge cynicism. If you're leading professionals, I don't care if they're engineers, preachers, doctors, or nurses, if you're leading professionals, they are independent, highly skilled, well-trained, confident human beings in general. And so when you meet with them, they don't always just meet you with this very cheerful, "It's great to see you. How are you? I hope you're fine. Everything's really ducky with us." They come at you with some real passion and emotion at times. And sometimes if you're not ready for it, haven't had some time to reflect or learn what I'm trying to teach, you take it very personally and very emotionally, and you go, "Oh my God, this is awful. They're just mad at me. They hate me." And you get into a shell, you get defensive. But there's at least 2 big groups out there. One are the dissenters. And this was this cardiologist who just gave me grief. He was a fire breather, and he was mad at me because he was disappointed in me. But the first time, he was double mad because he thought I'd lost my values. He thought he couldn't trust me. 4 meetings later, he said he could trust me, but I was still wrong. This guy brought me solutions. He didn't just say, because the cynics, when I say challenge cynicism, the cynics sit on the sidelines with their arms folded, just telling everybody how bad everything is. They're just passive and checked out and unhappy. And it's actually a sport for them. They're just trying to, play with people. They're not offering any solutions. They often don't have any passion other than just disappointment. And I said, that doesn't help me. But the dissenters, valuing dissenters, because they come at you, they're emotional, which means they care. They're emotional because you have hit a part of their soul that says, this isn't right. And so they will come forward with solutions, and that allows you to listen and acknowledge. And so it's interesting. You take that whole book, and I've got 2 slides I use all the time: value, dissent, challenge, cynicism, and listen, acknowledge, and challenge. Those are gold. Those are gold. And especially when you start out, again, to your colleague's question, because you're so inexperienced and you don't have a mentor and you don't have a lot of people necessarily that are in the same boat with you. This is a very important way for you to understand the simplicity of self-development, and then to find a few people around you who can help you. But those are important. And by the way, you can't, when it comes to difficult crowds, difficult challenges, and difficult issues, the worst thing you can do is delegate the hard stuff. Just say, well, I'm going to send my chief out for this discussion because, you're doing a major change that affects the whole organization, and you're going to send a middle manager out to do it because, you've got to go to a conference. The hardest problems require the most senior person to step forward, not for every detail and every meeting, but they need to step forward and say, I'm here. I understand you're angry. Let me tell you what I know. You tell me what you know. And it doesn't happen magically, but it happens, and it happens regularly and predictably, but you've got to have that. So when I talk about you asked me one question and some notes about what do I think are important for leadership, and just a few things, and it's not an exhaustive list or even an unlimited list. The first is integrity. Integrity is so important because the currency of leadership is trust. And if people don't trust you, then you better be a manipulator or a bully or something, because trust is the way you actually lead, especially respected professionals like nurses, doctors, pharmacists, IT professionals. So integrity is number one. Second is professional respect. If you're not known as a good GP, it's really hard to lead GPs. If you're not known for being a competent IT person, it's a little hard to lead in that space. That's kind of simple. The third one is emotional intelligence, which is how you understand how you manage yourself, your self-awareness, your empathy, your ability to relate to people with compassion as a human being. Some people have it, it's natural, others have to develop it. The fourth one is an enterprise view. We often get locked down into the misery of our own daily reality and our teams or our part of the organization. The more you can have an enterprise view, the more credibility you develop, and I'm going to talk about credibility. But the enterprise view says, I'm not just here to defend my turf. I'm here because all 60 people in the room are part of my community. And the last one is passion. If you try to go into something like major leadership with a flat affect and not a lot of enthusiasm, good luck. And so I mentioned credibility. And there's two parts to credibility that's important for us to remember, because we tend to focus on and remember what it takes to be half credible. And credibility comes from, number one, your ability to influence. Can you make a case? Can you show your knowledge, your impact, your reasoning, and your vision? And can you influence people? So credibility comes first from your ability to influence. But unhappily, or unfortunately, or realistically, that only makes you partially credible. The other side of credibility is you demonstrating your willingness to be influenced. So in other words, if you're just half credible, then you have to be omniscient. Because you got to always be right. You got to always throw the right answers out to people. But your willingness to show that you are vulnerable and willing to listen and learn, that's how you become fully credible. That's how a guy goes from saying your values are wrong and you're crazy to saying your values are okay, I'll work with you. Very important. The ability to listen and show that you can be influenced. And it's hard because when we're in these leadership positions, we have a lot of responsibility, and we have high-powered people who are sometimes our good friends who we're trying to create change that they don't necessarily understand or like, and they makes them unhappy. And it's hard because you'd like to say, okay, I'm just going to be right and tough and be a big mouth and speak out with great charisma. And that just doesn't work. So lots of words there. You asked a small question and I turned it into a lecture. I'm sorry.
It's fine, Jack. And I was just counting the amount of times you would have said listen in the last 5 minutes. And I think it was about 36. So listening is absolutely an essential part of leadership.
I did not know I was a good listener. I'm not sure I was a good listener. But the fire of my inexperience and passion said, I can't read enough books. If I read all night, I can't read enough. And then if I read it, it's like the question, how do I know? I'm out there trying to do the right thing. Then I'm surrounded by people who don't necessarily get it. So yeah, listening it's just amazing. It's so valuable.
Absolutely.
And it's not listening, waiting for your answer to have a moment for you to pounce out and give your answer. It's listening to say, wow. Good listening often uses the word wow. I'll go, I actually never thought of that. And sometimes people that are mad at you, they all of a sudden their anger gets really less because they go, yeah, you're listening, right? Yeah, I'm shocked by what you told me. So that's authenticity, that's integrity, that's trust is the currency of leadership.
Now, I wouldn't be doing my job of listening too well if I didn't give you the other questions that the audience has asked us. There's a couple, and so obviously your comments are making people quite excited. But if you don't mind, just going back to that point of the 21-year-old idealist, I think this ties in quite well in regards to how we empower people at that sort of stage in their careers. And there's a question from Fiona Doolan Noble. Do you think interprofessional education has a place where undergraduate health professionals learn together and improve competencies like leadership and followership, managing confrontation, patient-centered care, etc., is key to the workforce of the future.
Yes, absolutely yes, hell yes, I do. What is interesting is that 21-year-old idealist, by the time she or he is through 2 or 3 years of medical school, they're much less enthused, they're much less excited, and they're much less happy. Our educational process is a very mixed bag, and part of it is because it is so competitive, and it is so hard to get to the top of the mountain in cardiology, to become dean of cardiology, the chief, that it's all about personal, professional competence and accomplishment. And it's about writing papers and writing books and those kinds of things. And they're just a singular track of personal investment and personal accomplishments and personal focus. And it's just so ingrained in the in fields that are based on intellectual prowess and academic achievement, et cetera. And yet the practice of medicine is a healing art, and it's a very different world, and we have to learn to work in teams. And so medical education today is at various institutions in very different ways, starting to look very differently at themselves, a different sense of self-reflection. I was at a meeting with a faculty group at the University of Colorado, where I live now, and the medical education that they are projecting, to your last questioner's inquiry, looks a lot like what she asked. And they didn't blow up the old educational process, but they asked students, and they asked residents, and they asked lots of people what might look different. And what's interesting is I saw a layering, a tiering, T-I-E-R-I-N-G, there was probably some T-E-A-R-I-N-G too, among the faculty. The faculty that looked a lot more like the students were enthused about a new world and a new change. And the faculty that looked a lot more like me were going, wait, what's going on here? What's going on? And I think that is so telling, because even though I've said I'm retired, but I'm trying to still make a contribution, I have to be very conscious that I can't try to bring people back to a world that no longer exists. And if I catch myself saying, well, in my experience, what used to work for us, there are some places for historical learning, but they should only be applicable in today's context. So it's right, education has got to change, it's got to be different, and it's changing slowly, reluctantly, and not easily.
I'm guessing one of the things that will work, Jack, is if we give all the educational institutions a copy of your book.
Well, let's laugh about the book. This is the book so far has cost me so much more than it'll make me, but it's a labor of love. And when I did it, because it was self-written, which was very risky, I said to the publisher, I said, I have no interest in this book being a commercial success. At which time he sort of slaps his hand down on the desk and says, never, ever say that to your publisher again. This is my job, is to publish the book and make it a commercial success. I said, no, I said, because you won't see it on the bookshelf in the Sydney airport, with a bunch of James Patterson novels or books about, life in the outback. But I said, here's what I think success looks like. The first year, it sells 1,000 copies. And out of those 1,000 people, 300 of them go, oh my God, this works. This makes sense. I'm going to buy 5 of them for my team. And the next year, those 5, I said, if it's successful, it will be successful on merit and on very germinal, very granular, person-to-person, finding it useful. So that's exactly what I hope, is people say, gosh, it's useful. I want to, and book sales and all that are so around volume and making money. And, I'm retired. I'm not doing this to make money, but I do find it very likable in my own sense of self to be at this group in Maine and find out 30 people had read it and they're going, I wasn't going to read it before the offside. I wasn't sure. And I read it one Saturday and I finished it on Sunday because it was so easy to read. And I kept going, I've never thought about this before. So we're trying to take hardcore clinical people, whether they're doctors or nurses, and say, we want to make you more confident. We want to make you more competent in a field where you're not formally trained. And they all know what it's like to try to make change with your peers. It's not easy, but it's learnable.
There's another question, if you don't mind, which is more of a money question, from Mohammed Hook, who's asking, one important thing that will affect Australia and New Zealand is money or funding in healthcare. Governments and bureaucrats are trying to rationalise costs and services provided in the healthcare system. Mohammed's question is, should medical professionals get involved in cost-effective delivery of healthcare, or should clinicians be only concerned with patient care? If you'd like your views on that, please.
Yeah. Well, that is such an important thing for us to contemplate. And my answer is 1,000%, we must be involved. We must be involved. And the reason is, if we continually and continuously consider cost versus quality an essential trade-off, then we have undermined our ability to be thoughtful leaders for patients, because it should not be a trade-off. There is enough overuse, underuse, misuse in healthcare, and there's enough opportunities for innovation that it is very plausible. And as a matter of fact, there are many places it's being done where you are actually seeing both improvements in quality and efficiency and improvements in cost structure. So we must never turn that over to somebody else, because then we get these two-sided answers, and we give the finance people inadequate context for them to be successful, and too much power, because we're not there giving them the full context of the conversation. And this is the two of you acknowledge, challenge, listen to each other, and build context. But if we think that cost or quality are mutually exclusive, then we're toast, because eventually somebody's going to make it about cost. Eventually somebody's going to make it about cost, because healthcare inflation is hitting corporations and city, local, and national governments right in the pocketbook. And they know how to ration. They just do silly things around rationing. And we know how to improve care. So that's one of the things I feel the strongest about, because for many years I was told, Jack, our job has nothing to do with affordability. Our job is great clinical care and quality. And I said, no, there is no high clinical quality of people that can't afford to come in and see us. We can have all the awards and all the best results on earth, and if people can't get in the door, can't come in, or can't afford it, what good is it?
Absolutely. So, Jack, another question here is in regards to looking after.
By the way, I do like those questions. You're right. These are people very thoughtful, and they trust this environment to ask tough questions. I love that.
Absolutely. Jack, you mentioned earlier about looking after our colleagues, and I think Jane's next question is in regards to some of this, but more specific question about how we care for each other and how we care for the teams, which might include the medics, the nursing staff, the allied health professionals, and the team is getting larger and larger. As you say, there's more IT people involved. There are a variety of other professionals involved in the picture of providing person-centered care and family-centered care. How do we look after each other? What are we doing at the moment? What should we be doing more of?
Right. Again, super question, and so important. So we have problems, maybe to the point of crisis in this global community, including the US. Uneven quality, uneven access, uneven equity, and career satisfaction that's very variable, from doing pretty well to really having trouble. What we cannot do is to solve them one at a time. We have to be thinking holistically around, how do these things fit together and work together? And I believe they do. I believe that more healthcare people are over frustrated and over angry than they are overworked at times, because the system or the IT program or the government or the compensation is so distracting and so, it holds them back so much. So I think it's extremely important. And it starts, like all programs, it starts with awareness. We have to know that our brothers and sisters are vulnerable human beings. And what I've learned in managing big groups of physicians, because we had to take on all kinds of performance issues, et cetera, if you don't take them on, somebody else will, whether it's a lawyer or a hospital CEO or somebody. But if we really care about our fellow men and women, we should take on the issues. We should be the people that care about them if they're having trouble. 5% of all professionals are having some kind of major problem. Health, mental, competence, quality, alcohol, marriage. 5% of all of our colleagues are having some sort of major problem. So if you deal with 1,000 people, 50 of them are having some kind of big trouble. You don't know who they are, because we all show up our best face at work typically. Those other things show up our way. So awareness that this is real and it's all around us, number one. Number two, that sensitivity that says, we're not just here to heal patients, we're here to heal our friends, our neighbors, and ourselves. When I took over the first job as the head of the physicians in Colorado, we had a plummeting physician satisfaction survey, to the point that our leadership wasn't showing it. And they were not bad people, but they said, there's nothing we can do about it. And I thought, well, then it's just over. But I said, how about if we just say, it's here, it's a problem. How can we start to talk about it? And we opened up the conversations. It took a few years, but we started to really make tangible improvements in the careers of people. So physician wellness was always considered a non-issue, because we were just so used to being hard worked, overworked. We're just tough. It's all about resilience. Well, resilience is important, but it's also about the holistic soul and spirit of a human being. And so there's a lot of energy, thank goodness, finally, looking at the careers of physicians, nurses, et cetera. And by the way, I got very interested in the nursing issues and nursing shortage early on in my career as a leader. And the reason I did was because a nurse brought me some very inconvenient articles who said, they were talking about nursing burnout. This was 20 years ago. And she said, if you worry about nurses being burned out, you should also worry about why. And number one or number two was how they were treated by doctors. What makes nurses unhappy? Number one or number two was how they were treated by doctors. She says, do you know any of those guys? And I said, I do. I said, and she says, number two and number three is how they're treated by nurses. They said, we healthcare providers don't necessarily treat ourselves and each other well. And it's that tough nihilist, where we're tough, we can do it all. And so I think it's to say, first of all, we acknowledge it, we recognize it, it's tough. How can we be more gentle? How can we be more aware of ourselves and each other? And it just happens one day at a time. It's hugely important. Finally, in this world, we're finally realizing that burnout is not an inevitability about hard work and bad insurance decisions. It's just a reality. And if we try to solve it by ourselves or being in small groups, we won't get it. I think it's extremely important. It's another extremely valuable question. We could do a webinar on every question that's been asked so far. We really could. They're all so deep and so important. And I didn't give you the answer to any of them, but I will tell you they are important, and we must not let them hit the ground and say, now we're going to go out and work on improving readmissions. That's important too. But if you want to get the discretionary effort, the soul and spirit of your colleagues, you've got to do it by saying, we care about you, we're going to make your careers go well, and we're going to be really, really mindful of each other. I show a slide that talks about 68% of physicians are sorry their doctors, 77% would never do it again. And you can debate the numbers, but they're real. And whether they're 50% or 80% doesn't matter. But I said to this group in Maine, I said, anybody wonder about the 28% and 33%? Why aren't they miserable? What is different? And I said, we need to understand also what makes some of these people happy. And then there are things that make people happy. But we have tried to solve so many of our life's problems alone because of our training and because of the ethos of being a professional. And it's just not enough. And that's why suicide and drug addiction and all these things come along. You know, we're just looking for ways to cope. And it's really sad because we are the patients. And we cannot just say, I will take care of the person across the table from me. I'm going to have to take care of myself, my nurse, my staff, my IT people. It's a mindset, but it's also getting knowledge. And, you know, when I started talking about physician burnout, I said, when I talk about burnout and doctors being unhappy, there's two responses that don't help me. One is, oh, the poor doctors, it's just awful. It must be terrible to be a doctor. That doesn't help me because that's just empathy. Or the one, tell them to get over it. They're well paid, they're well respected, it's a great profession, tell them to get over it. That doesn't help me. What helps me is to say, okay, let's create the hypothesis of why doctors are happy or unhappy. Let's do some data gathering. Let's get some potential interventions. Let's study it. Let's treat it like we treat cancer or other things. Let's make it a scientifically relevant venture of trying to find out why people are burned out and miserable and unhappy. So we're getting there. We're doing that. We're starting to do that globally. There's so many things that we've talked about in this call that are, it's like the little engine that could, you know, the wheels are turning. I just want to live long enough to see the wheels spinning.
Fantastic. Now, an hour has flown by very fast, Jack, and there's so much more we can talk about. And there's a couple of questions that are left unanswered. But I hope you don't mind. The last question that I'll ask you is, what is the one thing that people should be doing next after they listen to this webinar? What's the next big thing that people should be doing now?
You had to save the easiest question for last, didn't you, Dad?
Can't let you off lightly, Jack.
Yeah. Well, I'll take a shot at that. And because these issues are so important and because they're so difficult, I think the biggest thing that people need to do is to just stop and reflect and just let it simmer a little, because this is not A plus B equals C, quick solution, or get all agitated and form a committee and all that. This is deep. This is about our professions, our vulnerable patients, our vulnerable colleagues. And when I say reflect, it was to say, what are all the issues? What is going on here? How can I start to frame my own self tomorrow morning to say, I've got to show up differently. I've got to stop being the victim. I've got to stop being the tyrant. I've got to stop being frustrated and saying, 5 more years and I'm out of here and I never want to be a doctor again. That's tragedy. That's tragedy. This is an honorable profession. And we have to continue to make it honorable, sustainable, relevant, fun. And I believe we can do it. If we give up on the professions of the healing arts, we're in trouble. We're in trouble. So we'll solve it. We will. The United States always has this sense that we've kind of got it figured out. And all of you who are not in the United States know for sure we don't. But one of our greatest, most thoughtful, most insightful critics was Winston Churchill. And one of his great quotes was that, Americans will always find the right solution to any problem after they've exhausted all the options. So I would say reflection and to start the conversation. Say, how are we going to show up differently? The next time I hear somebody say, oh, those IT people are a bunch of blankety blanks. Well, how do they understand what we need and how do we understand what they need? This is a team sport. This is not, let's get smarter. You do not need smarter doctors and nurses or executives in Australia. You need a system that's going to work together around a sense of a common, lofty goal, which is to save the healthcare professions for patients and families so that we get great, safe care and we can eliminate some of the inequities and some of the other things that plague us. So it's a highly personal time of reflection.
Wonderful, Jack. Your enthusiasm fills me, at least, with a lot of hope, and certainly you're getting a lot of questions from the audience. As I mentioned, some of those are unanswered, but look, certainly I would, and you're not going to do this yourself, but I would certainly recommend Jack's book, Leader, Healer and Partner, for everyone to read. There's a lot of the questions that were asked by the audience. There certainly is at least some initial answers in that book. But hoping now whether you can join me in a virtual round of applause for Jack, and hoping that I can throw the floor back to Lisa. Lisa, are you there?
I am. Thank you both, Jack and Jas. That was really fantastic. Apologies.
You see my hat?
It's a great hat. Apologies for the delay in the video. Zoom decided to change some settings on us.
I'm just relieved it wasn't me.
No, it definitely wasn't you, Jack. It was me. So thank you again. It's been fantastic. For everyone listening, we do hold webinars on topics related to value-based healthcare and innovation every month. We will be releasing information on next month's webinar shortly. You can always check our website or sign up to our mailing list for more information. But thank you everyone for joining us. I hope you have a great day, and thanks once again to Jack and Jas for a fascinating conversation.
Thanks to all of you.
Thanks everyone. Thanks for having us, Lisa.